It's my pleasure to introduce to you Brenda Zimmerman, who is an associate professor of strategic management at the Schulich School of Business at York University. Her primary research applies complexity science to management and leadership issues in organizations experiencing uncertainty and turbulence, especially healthcare and not-for-profit organizations. Sounds like a busy field right now. She's the founder and director of the Health Industry Management Program for MBA students, an associate faculty member for the Social Innovation Generation at the University of Waterloo, and director of the Ontario Medical Association, Canadian Medical Association Physician Leadership Development Program. Former member of the Canadian Academy of Health Sciences Chronic Disease Expert Panel on Health System Transformation, and the Royal College of Physicians and Surgeons Health and Public Policy Committee. She's currently an advisor to the Public Health Agency of Canada's Chief Public Health Officer, chair of the Patient Safety and Quality Committee at Mount Sinai Hospital, and a board member for the Center for the Evaluation of Health Professionals Educated Abroad. Please join me in welcoming Brenda Zimmerman.
Well, I'm delighted to be here. I know there are some amazing things that are happening in health transformation in Colorado. We import a number of them into Canada. So I'm here not to tell you that I have all the answers, but to hopefully sort of shine a light on some things that you're doing that you should need to continue to do, and to also tweak some of these behaviors that you've been involved in terms of truly getting into that engagement behavior that we heard about from the first three speakers. I think my role today is really to take some of the points that were made by the first three speakers, by Alan and Mark and Laurie, in terms of what needs to be, who needs to be engaged, and what kind of engagement needs to happen, and focus more on the how. How, and Laurie started to get into some of that in her presentation as well, but I want to pick up on that. And so I've decided to start with something that's really novel, really exciting, a new clinical experience that some of you, I'm sure, have heard about, and that is, bloodletting. So before the organizers have a little bit of a problem here, and Sally does drop the F-bomb about why they invite this Canadian to come talk about bloodletting, how exciting and new is that? I want to set the stage here because bloodletting to me is a fascinating story in healthcare about how we can intellectually understand something, but it can take a long time for our behaviors to change. So if we go back a long way ago, 5th century BC, bloodletting was sort of the name of the game to treat almost any illness by the Mesopotamians, the Egyptians, the Greeks, etc. And when you think about it, they had some hypotheses. They believed that blood was created and then but they didn't know about circulation, so they believed it would stagnate. So the blood at your extremities would start to go bad, and so you had to sort of get rid of that bad blood. Second hypothesis or theory they were basing bloodletting on was the fact that there was the four humors that the Greeks talked about that kept our whole bodies in balance, and they were blood, phlegm, yellow bile, and black bile. And so we needed to keep these things in balance. And so years and years, centuries after these theories were refuted, these hypotheses were refuted, we continued to use bloodletting across the globe for all sorts of different diseases. It still was the as typical as take 2 aspirin and call me in the morning kind of treatment. What happened over the years is that we got more sophisticated in bloodletting, right? We sort of did, in today's language, we'd say we Six Sigma'd it, we TQM'd it, we leaned it. But we figured out how to do it faster, better, what the appropriate contexts were to do it in, etc. But we didn't actually challenge the behavioral paradigm of bloodletting, even though intellectually there were some real challenges that we struggled with in our understanding of bloodletting. So what's the real paradigm of bloodletting? Bad stuff's in the blood, so therefore if we can get it out, we can have a healthier patient. right? And if you don't challenge that concept, you can end up having behaviors that can be very sticky for a very, very long period of time. To me, I would argue that we have the equivalent of bloodletting paradigms in terms of our behaviors in health system transformation. I believe that we are still wedded to models of change and how things happen, even when we know intellectually or have hypotheses or maybe even good evidence that they don't work. And yet we still use approaches that fit more with that other kind of approach. And so I think today our challenge is to sort of say, where are we sort of being blindsided by our own bloodletting behavioral paradigms? And so if you think about, there are several types of problems. And I'm using this in a sort of playful way, but I actually think there's a profound distinction here between these categories. Some problems that we face in healthcare transformation are indeed simple. They are like baking a cake. You can know ahead of time what ingredients are needed, what steps to do that should be taken, temperatures, et cetera, et cetera. And if a recipe is really well written, you don't have to have any great expertise to be able to create that cake. Knowing how to cook helps a little bit, but generally speaking, if a recipe is well written. So there's lots of the work that we're talking about in health system transformation, and even in talking about engaging new behaviors, that relates to the simple. But there are problems that go beyond that, complicated, more like flying a rocket to the moon. When we're flying a rocket to the moon, now we need expertise in all sorts of different disciplines. And we need to coordinate that expertise. But like baking a cake, every time you send a rocket to the moon, it increases the chance of the success of the next one. You have that lovely exponential linear growth pattern that you've got. Formulae are very important when you're dealing with sending rockets to the moon. My argument is, in Western society, we have legitimized complicated modes of thinking. We believe we should be able to figure out if we have good enough formulae, good enough data, good enough evidence, we can figure it all out. And so we continue to use those kinds of approaches even when we go into a third category of challenges. Sorry. Raising a child. How many here are parents? How many have more than one child? Phew, excellent. How many here have been in a romantic relationship? Hopefully the parents will put their hands up too. Okay. So, because you can substitute romantic relationship for raising a child here. When we are dealing with a context like raising a child, a romantic relationship, we're talking about a qualitatively different phenomenon. Right? Recipes have much more limited application. Formulae have less limited application. And it doesn't mean that we're not going to be thoughtful and try to be good leaders, if you will, in that kind of context. But we all know it's a different kind of process. There are no one right recipes. There is no right protocol. You can read all the books on parenting you want, and you're not going to get it perfect just by reading those books. It's very much, when we talk about in complex systems, the unit of analysis that has most explanatory power is the relationship between the parts, not the parts themselves. The relationship between the parts. Hence, we need to be as rigorous in our analysis of the relationships between the parts when we're talking about engaging behaviors as we are the parts themselves. So, how many of you have strategic plans for your children? As a strategy prof, I'm deeply offended. So now there is some giggling, and there's probably were some people who tentatively want to put up their hands. They usually have very small children. But we laugh about that because the strategic plan process that we typically think about is first we figure it out and then we go in and implement it. But when we're dealing with a relationship as intimate and as complex as a child or your intimate partner, you know that it's a much more iterative process. I believe you need to be very strategic in raising a child, very strategic in your romantic relationship. But I don't think it's about strategic plans. Right? I think it's a different form of strategic thinking and much more tight iterative feedback loops. Let me ask you another question. How many of you are coherent in your parenting? Okay, we'll get back to that. Okay, so one of the reasons I like that image of the simple, complicated, complex is it sets it up as a contingency framework. It doesn't say we should be treating everything as if it's complex. There are certain things that do indeed are served well by simple and complicated interventions. And so part of our leadership job is to discern what kind of context are we facing right now, and are we using the right kind of heuristics, approaches, etc. for these kinds of things. So one thing we can do when we're facing complexity is we can ignore it. So this is a statue. Some of you may have seen this statue before. It's in Berlin. It's the world politicians gathering at a meeting to discuss climate change. I'm sure the irony is not lost on you, right? So here you are. If you decide to ignore complexity, it will come back to bite you anyway, or in this case, drown you. So there is that sense that we can't pretend complexity doesn't exist. It just is. It's part of what we do. So many of us are engaged in complex personal relationships, and we do that because they enrich our lives as well as complicate our lives. But they're critical to our own development here. And so if we don't want to ignore complexity, then we just sort of think about how do we embrace complexity? How do we truly embrace and engage with complexity? And why do we need to do that? Well, because things that never happened before happen all the time, right? And so that is the nature of complexity, that we have to be prepared for the fact that there are going to be surprises. One of the times when I'm brought into an organization, a hospital or social service agency or a government, and they say, okay, I always tell my staff, the one thing I never want is a surprise. And I think, okay, that's problematic, because if you're dealing with complexity, you are going to be having surprises. So our job is not to eliminate all surprises. Our job is to sort of be able to cope and respond and react to those surprises. Now, having said that, go back to that contingency framework I had earlier, there are times when we actually do want to reduce complexity. It's absolutely appropriate for us to reduce the number of steps in a procedure to improve patient safety. Right? That's perfectly fine. So part of what I'm talking about is not that kind of reduction of complexity. I'm talking about the relationships that are naturally inherently complex, ecosystems, health systems, family systems, relationships between a physician and a patient, or a physician team and a patient. Those are the ones where we can't eliminate all the complexity, and we need to learn to embrace it. So this is an image, which could be an image of a whole variety of things. It could be a beautiful galaxy. It could be fireworks. It actually is taken from a social network mapping work that we did in a couple of healthcare organizations. And each color represents a role in the organization. So green could be physicians, blue could be nurse, pink could be physio, yellow could be patient, whatever. And what we're trying to do is we're trying to map out the messiness, the complexity of the relationships of who connects with whom. And the reason we do this is we say putting on the org chart doesn't tell us enough. The org chart is a very limited way for us to understand how information really flows, how connections are made, and therefore how change is really going to happen in an organization. Embracing this complexity may allow us to start to see some things. So you see some of the dots on the outer edges, those people aren't connected. Right? So if they come up with a brand new, exciting new initiative, they're going to have a heck of a time trying to get that embedded in the DNA of the organization if they don't understand where the nodes are, et cetera, in that kind of system. So embracing complexity is a legitimate, I would argue, alternative to avoiding complexity, and it's going to be a necessary one for us to truly talk about engaging behaviors, especially as all three speakers talked about fundamentally talking about patient-centered care. Not the lip service, but fundamentally having the patients be part of the system is going to require us to engage with them in a different way, not just consultations. So one of my jobs that Alan alluded to as one of my volunteer roles is I'm the chair of the Patient Safety and Quality Committee for a large teaching hospital in Toronto. So it's really interesting. Patient safety and quality is often linked together, right? We talk about patient safety, quality groups and committees, teams, organizations. And yet, to me, the approach I need to take for the patient safety side is quite different from the quality side. For the patient safety side of the work, I think a lot of the work I have to do is increase reliability as in replication. I want to be able to sort of show, like a checklist, that if we do these 5 things and always do these 5 things, it reduces the chance of medication error, or it reduces the chance of another kind of error that you could have in a clinical setting. So and I'm not wanting to diminish those things. I actually want more of this. We want this kind of approach, and we want to get better and better. And that's where the human factors engineering is so powerful, et cetera. So this is all absolutely appropriate for us to think about these things. But to me, I think at some level, if we go too far with these things, we do it at the expense of quality. Patient safety taken to an extreme can be at the expense of quality. Now, that may seem an anathema, but what I mean by that is I think when we're talking about patient-centered care, we're really talking about the holistic patient. We're talking about the messiness of their social, cultural, geographical, religious, as well as their biological and medical kind of conditions. And if we really want to understand and work with them in that context, we are going to be able to, we cannot follow a basic checklist kind of approach. And this to me is reminiscent again of raising a child. So I asked you how many of you had more than one child. Can I see those hands again? Okay, so raising one child gives you no assurance of success with the next. Okay, that's one of the rules of parenting. So I have 2 daughters, and I have sort of nicknamed them Urban Girl and Bushwoman. And here they are. I bet you can tell who's who. Okay, so Bushwoman forgot her shoes for her sister's wedding, as you can see. And Urban Girl was wearing quite high stilettos under her dress. So here they are. These girls came from the same parents. They had the same food when they were growing up. They lived in the same house. They went to the same schools. You can imagine I had to parent them in incredibly inconsistent ways. Right? The coherence of my parenting was some meta rules, but how they played out was radically different. The limits that were needed by one was radically different than the limits for the other. And it continues to be the case, as you can see this picture that was just taken 3 or 4 months ago. And Bushwoman's dad kept saying to me, Brenda, can't you get her to put her shoes on? Nope. Okay, so I believe that good parenting is not necessarily consistent parenting. I believe it's coherent parenting. Coherence allows us to have the quality experience that is context-specific within a clear set of boundaries of no-go zones. That's, I think, what we need in public policy. We need coherence in our public policy, not necessarily consistency. And I think that's a really tough thing for us to get our head around, because we've treated these 2 things as synonyms, right? That we have to have consistencies, equity, consistency, therefore, and coherence are all the same thing. And I don't believe they are. I believe we do need to think about these things differently. And so this moves me to the next point, which is resilience is a key part of leadership and engagement. And resilience here is not the engineering type of resilience where you build a bridge that can handle sway and wind and change in temperature and snap back to its original form. I'm talking about biological or ecological resilience. And in that case, we're talking about adaptation. We're talking about being able to absorb difference, absorb change in profound ways, right? So it's again, keeping the coherence, but still being allowed to absorb those changes and those differences. And so that, to me, I think is a key part of when we're going to think about the quality side of engagement, we need to think about resilience and that, open to surprises. So we do have this tension between reliability, which we want, and resilience, which we need. We need both of these things, and they're going to be in tension. One of the things that we have in the Western world is when we see things in tension, we often treat them as contradictions, right? Two opposites can't both be true in a contradiction. And yet, the reframing that Laurie was doing in her last presentation was flipping those opposites and sort of saying, rather than treating them as contradictions, let's treat them as paradoxes so we can have both at the same time and ideally breakthrough thinking. But unfortunately, in Canada and the US, and even our religious structures, etc., are not very familiar or not very comfortable with paradox. We're much more comfortable with right, wrong, this way, that way, right? Truth, black, white, etc. And so we often will take opposites and treat them as contradictions. So when I did my MBA far too many years ago to remember, I was taught that it was appropriate for in all organizations, all industries, you had to choose. Are you going to be the low-cost producer, or are you going to be the high-quality producer? You couldn't choose both, because choosing both would be in this horrible place, limbo, I guess, in strategy land, that Michael Porter at Harvard would say is called stuck in the middle and nobody wants to be there. So for years, we advised organizations, healthcare and other organizations, choose which direction you want to go in. Meanwhile, in the East, where they're much more comfortable with paradox, they said, how can we, questioning things the way I call wicked questions, how can we dramatically improve quality while drastically reducing cost? And by asking those questions, wiped out several North American industries. All right, industries that were started in the US, televisions, cameras, photocopiers, etc. But because we were always going, we never want to be stuck in the middle, we were high cost, low, or high quality, no, low cost or high quality. We didn't want to mess these two worlds. They messed those two worlds, they morphed them, and they had a dramatically different impact. We still in healthcare talk a lot about cost or quality. It still, unfortunately, is a mantra that's heard far too often, and it flips into the way we make a lot of our choices. So that paradox of holding those two things together, I think, is critical. Not just reliability and resilience, but a whole variety of different paradoxes. So to embrace complexity, you have to embrace paradox. To embrace complexity, you have to embrace uncertainty and surprise, unpredictability. To embrace complexity, you have to be willing to try different kinds of approaches. And I've alluded to some of them already in my talk today. I think there is a contingency framework that works quite well in terms of discerning between simple, complicated, and complex. I think you do need to set high-level meta rules or boundary conditions within which you can nudge your strategy as you go through. I think you have to be much more attentive to patterns as they are unfolding, to sort of see what direction they are going, to see whether you can nudge them, if you will. And I think wicked questions are a great way for us to hold the tension between those paradoxes, particularly when we keep going back to the old ways of doing things. So I am going to spend some time in the discovery session this afternoon going into some more specific examples of the actual techniques and interventions. So if any of you will join me there, we'll spend time with that. We'll do very practical things looking at the challenges you're facing. But I do want to highlight a couple more just as a bit more of a tease before I end off my session here. One is when you're dealing with complexity, one of the things that we don't want to deal with is buy-in. Buy-in is the death to complex systems when you try and transform a complex system. When you are dealing with buy-in, you've got a seller and you've got a buyer. Somebody's trying to sell you something. And we so often, and healthcare is not unique in this, and perhaps it's even more so, there's that immune response that's a reaction that's set up. Well, I don't want to be sold something that wasn't created by me. So there is that sense of resistance, even if it's subconscious. By the time the seller leaves the building, so to speak, people flip back into their old ways of doing it. It may only take a week, it may take a month, it may take a year, but the buy-in is a very superficial way of getting deep engagement in systems. So as soon as you hear in your mind or in the language of talking about in meetings, and you're starting to talk about buy-in, recognize that you're probably talking about something that can be done very fast, but likely won't last. Okay? The contrast to that is ownership. Ownership is when the players who are going to actually be doing the work, who are going to be involved in it, actually feel a sense of ownership of that. That is different than just consultation. So if we're talking about, for example, with patient engagement, we want true patient engagement. If you really want them to own their own health journey, that was picked up on some of the pieces that Mark was showing in his last slides, I think, and Lori was showing some of her pieces as well. If you truly want that ownership, they have to be not just consulted and then told later about what you heard from them, but actually truly engaged in that. And I know a number of you here are doing terrific work in that arena. As I said, we are looking to Colorado for various insights and some of this stuff that you are doing here. But I still think the main in healthcare is not to do that. The main is fake ownership, right? It's very superficial. We consult, and therefore we say, you now own it. And we see this in far too many places. So we need to think about how we can actually get patients and families truly in the room to be part of this. Okay, another little tease. What do you think this is? Birds, that's right. It's a flock of flamingos flying over Lake Tanzania. So when you think about how a flock of birds move, or a school of fish move, how do they move? Describe it. Together. I see people's hands moving, sort of waves. Fast, slow? Fast? Okay. So typically when we think about a situation like this, and we sort of want to know, well, how did that happen? How does that flock of birds move so quickly and so coherently from place to place? And so typically when I ask, and this group is a little larger, so I won't do this in a large group, but typically when I ask, I'll get a hypothesis of something like, okay, well, one of the birds was closest to the threat, the predator, the wall, whatever, and they recognized that threat and they communicated that somehow out to the rest of the flock, right? So if that was the case, how quickly could the flock respond to the stimulus of danger compared to the individual bird? It'd be a bit slower, right? You're going to have that lag time as it sort of ripples through. It might not be very long, but it's going to be a lag time. Well, in actual fact, when birds are in this flocking formation, which in complexity science we call self-organization, they are ultra-sensitive to their environments. They can respond to a stimulus collectively up to 50 times faster than any individual bird could respond to that same stimulus alone. See some frowns around the room. You cannot explain this by the parts. The rule, remember I told you the relationship rule, or the unit of analysis that we have in complexity is the relationship rules. So what you have to do is you sort of say, okay, we can't explain it by the smart bird phenomenon. We've got to explain it by the rules of relationships that all the birds are following that are creating this coherent kind of behavior. And so Craig Reynolds, a computer scientist who was trying to simulate flocking of birds, and he came from Brooklyn, New York. Anybody here from Brooklyn, New York? Okay, so you might be understand what he's talking about. He said, so he'd go up and he'd say, today I'm going to talk about boids. And they'd say, what? What's he talking about? Boids. Anyway, he finally, of course, he's talking about birds. But nobody can understand what he's talking about. So you can actually see his simulation of boids on the computer. And so what Craig Reynolds did was studying with biologists, trial and error in his computer. He put in 3 relationship rules into his simulated birds or simulated boids to create this ultra-sensitivity to their environment. So they wouldn't hit a wall, so they wouldn't hit a cliff, they wouldn't be eaten by a predator. And the relationship rules were basically things where pay attention to what's going on around you. They were match the speed of your neighboring boids, don't bump into anyone, and head towards the perceived center. You have to get the rounded edges, those kinds of flocks. Now, his simulation is not Mother Nature's rules. His simulation gets the boids to behave about 35 times faster to a stimulus. But the point here is by looking at those min specs, those few simple rules, it could have had incredibly powerful explanatory power. That was a terrible sentence, but I hope you understood what I was saying. It had unbelievable sense of being able to explain what was going on, much more so than our linear methodology of looking at our explanation of a complicated. First, you got a leader, then the leader presents the information, blah, blah, blah. So it seems to me self-organization exists all the time. When you take a look at our organizations, we're always seeing self-organization, and it isn't necessarily good. Self-organization isn't a good thing, isn't a bad thing. It's a pattern that repeats because of rules of behavior which may never have been written down, patterns of interactions that repeat over and over and over again. Certainly those of you who've been involved in family therapy, that's what you do, right? You work on the dance steps. If you can change the dance steps, you can change that. This, to me, says in complex systems, one of the ways that we can intervene in a very powerful way is if we can start to identify what those simple rules of behavior are that are holding the system in its current configuration, we may be able to intervene at the level of the rule and therefore change it in a positive way. We can also say, leave it alone if the rules are working perfectly fine, too. So that's another sort of way of sort of thinking about other ways of thinking about how do we deal with complex systems. So to me, the parenting metaphor says, we already know how to do this. And we look at ecosystems and other kinds of things, we sort of say, the world has figured this stuff out. Our job here is to sort of be a little more articulate about it, surface it, not be embarrassed by it, to describe it in these particular ways, and to hopefully get some more power to improve health outcomes at better value for all of our citizens and our patients. But the bottom line, going way back to that bloodletting story that I told you at the beginning, paradigms of behavior are very difficult to change. And in healthcare, probably more so than in many industries. So we have to be ever vigilant about those and be very deliberate in terms of how do we change those behavioral patterns. But let me end with one of my favorite quotes, which is why I think this is doable. And this is the quote that I got from Dee Hock, who was the founder of the Visa credit card system, and then used complexity principles, and then went on to take those same kind of insights into early childhood education. And here's his quote. Time is too short and things are too bad for pessimism, so clearly we just have to move on with this stuff. So anyway, thank you very much. I hope that was a useful exercise.